I hope that we can make this session interactive. If you have a point to add or a point of correction, please unmute because I can't see the chat box. So you can unmute and say anything. So first we have this. What specimen are the strips above used for? First, it's important to identify the strips. It's a urine dipstick used for urine. It's used to test for diabetes mellitus, glucosuria, chronic kidney disease, liver disease, proteinuria, and ketonuria. The parameters that are found in this urine dipstick, basically the colors, the parameters represented by these colors here are pH, urine-specific gravity, heme, leukocyte esterase, protein, glucose, ketones, urobilinogen, and nitrite. Name the item above here. This is a Bijun bottle. It's used to collect blood and body fluids for biochemical assays. This container here is a polypot. It collects stool that tests for occult blood or stacobilinogen. Name the anticoagulant used in the J-top Vacutainer. It's sodium fluoride. Sodium fluoride inhibits glycolytic enzymes, so it's useful in performing serum glucose tests and lactate tests. The item above is a universal bottle. It collects random urine, and random urine can be used to test for HCG in pregnancy, can be used in dipstick urinalysis, Bradshaw's test for multiple myeloma, Hayes test for liver disease, and urine microscopy. The device above here is a glucometer. It's used to test for random and fasting blood sugar. And the reference ranges for random blood glucose are 3.2 to 7.8 millimoles per liter. And for fasting blood glucose, the ranges are 3.2 to 5.5 millimoles per liter. This amber bottle here is a Winchester bottle. It collects 24-hour urine, which is used to test for acid-fast bacilli, VMA test for pheochromocytomas, creatinine clearance tests, cortisol, and microalbuminuria. Going through the Vacutainers now, apart from the gray top Vacutainer that we've covered, we have first a red top Vacutainer. It doesn't have an anticoagulant and is used in serum biochemistry tests, for example, a Coombs test, and therapeutic drug monitoring, like phenytoin and methotrexate. It has other uses, so it's important to read up on it in case you're asked about 4 uses. A light blue Vacutainer contains sodium citrate as its anticoagulant and is used in coagulation studies like the prothrombin time, thrombin time, and D-dimer. The limitations of sodium citrate is that it inhibits alkaline phosphatase and aminotransferase. A purple top Vacutainer has EDTA as its anticoagulant, and is used in CBC tests, PBF, ESR, reticulocyte counts, HbA1c, and monospot tests. The limitations of EDTA is that it inhibits leucine aminopeptidase, alkaline phosphatase, and creatine kinase. A green top Vacutainer contains heparin as its anticoagulant. It's used in blood gas analysis, lactate tests, ammonia, and insulin. But the limitations of heparin is that it inhibits acid phosphatase, it inactivates lactate dehydrogenase, it has a temporary action, and it's expensive. A black top Vacutainer, E here, it has sodium citrate as its anticoagulant and is used in pediatric ESR tests. A white top Vacutainer doesn't have an anticoagulant and is used in molecular diagnosis like PCR and DNA amplification. A yellow or a gold top Vacutainer is known as a serum separating tube. So by its name, it's used in tests where you require the serum, like UECs, CRP, LFTs, TFTs, bone profile, lipid profile, tumor markers, toxicology, drug levels, etc. And finally, a pink top Vacutainer contains K2-EDTA as its anticoagulant and is used in blood bank tests. The device below here is a pulse oximeter. It measures oxygen saturation, of which its normal reference ranges are 96 to 99%. The method of separation indicated below here, this luminescent green one, is gel electrophoresis, and it's used in separation of proteins, immunoglobulins, and isoenzymes. And now, the second last thing we have is serum protein electrophoresis. So these three show the normal. And an easy way to remember is to make this shape with your right hand. The first, the pinky represents albumin. The second, the alpha-1 globins. The middle finger, alpha-2 globins. The third, beta globins. And finally, gamma globins or immunoglobulins. And it's important to know where each protein is produced and its function, because that helps in interpretation. So I think to break up how monotonous the session already is, if you know any function of haptoglobin, ceruloplasmin, alpha-1 antitrypsin, or immunoglobulins, you can put it in the chat so that when we're looking at these pictures here, it can help us identify what the issue is. Thank you to everyone who's put something in the chat box. Alpha-1 antitrypsin inhibits serum proteases produced during inflammation. That's true. So alpha-1 antitrypsin is used in diagnosis of emphysema and liver disease. Albumin is used in binding drugs and hormones and maintaining osmotic pressure. Yeah, that's also accurate. So for the rest, since we've already talked about albumin and alpha-1 antitrypsin, for the alpha-2 globulins, haptoglobin is used as a diagnostic clue when someone has hemoglobinuria. And ceruloplasmin is a diagnostic clue in Wilson's disease. Alpha-2 macroglobulin is a diagnostic clue in nephrotic syndrome, and transferrin is used to transport iron in its ferrous state. So having discussed that, in this first clinical picture here on the left, assuming that the black are the normal baseline levels and the blue are the patient's levels, we can see that alpha-1 and alpha-2 globulins are increased and everything else is normal. So this points towards acute inflammation. Note that in acute inflammation here, the albumin can also be decreased. The second clinical picture on the right, albumin is decreased, and not only is alpha-1 and alpha-2 globulin increased, so is the immunoglobulin. So already remembering that alpha-1 and alpha-2 signify acute inflammation, a surge in the gamma globulins together with these two points towards chronic inflammation. In this second clinical picture, the albumin can also be normal. So for the acute and chronic inflammation, remember albumin can be normal or decreased. For the third picture here on the left, albumin is decreased. Alpha-1 globulin is decreased. Basically, everything else apart from the alpha-2 globulin is decreased. Sorry. Remember, one of the components of the kind. No, I don't know what I've done. Anyway. Yeah. One of the components of the alpha-2 globulin is the macroglobulin. And macroglobulin has a very large molecular weight. So in cases where there's nephrotic syndrome, all the rest will be filtered out by the kidney, but alpha-2 macroglobulin won't be filtered out because of its large molecular weight. So it's still in the body, and that's why there's a high level. So this points towards nephrotic syndrome. I hope the explanation makes sense. If it doesn't, you can unmute because I can't see the chat box. For the fourth picture here, everything else is decreased apart from the immunoglobulins, which is increased. This points towards liver disease, like liver cirrhosis, yeah. And finally, this fifth picture here, it's very obvious that there's a spike in the immunoglobulins, and it's very different from this fourth one where it's like a steep rise as compared to this last one where there's a monoclonal spike. So that can be a pointer of multiple myeloma, monoclonal gammopathy of undetermined significance, plasmacytoma, Waldenstrom's macroglobulinemia, amyloidosis, and plasma cell leukemia. Finally, there are 3 case studies here on CSF interpretation. So the first important thing to remember is the clinical picture, basically how a patient with increased intracranial pressure presents. Most of the time it's with headaches, photophobia, nausea and vomiting. They can be drowsy or confused, but they are arousable to command. Normally CSF is clear and colorless, but if it's turbid, it signifies that there are white blood cells or pus present in the CSF. If CSF is red, it means that there are red blood cells there. And if it's yellow, it can point towards jaundice. Okay. So having that in mind, looking at the first case study here, I'll just go through the investigations and the CSF findings. On hematological testing, the white blood cell count was increased. I hope you can see. The white blood cell count is increased. The platelet count is within normal range. And on physical appearance of the CSF, it was turbid and formed coagulum, so that already points towards the presence of white blood cells. The pressure is significantly increased. Protein is increased, glucose is decreased, and chlorides are decreased. On CSF microscopy, leukocytes were present when they're usually absent. Lymphocytes are slightly increased, and on gram stain, there was intracellular diplococci. So what's the probable diagnosis here? I think to save on time, I'll just do it quickly. It's probably acute bacterial meningitis. This is because of already the presence of intracellular diplococci on the gram stain that points towards the bacteria being there. But an increase in leukocytes and specifically neutrophils points towards bacterial meningitis, while a significant increase in lymphocytes points towards viral meningitis. So although they are both increased here, lymphocytes are increased by a lower margin as compared to leukocytes. So that's an easy way to tell apart the two, between bacterial and viral meningitis. Apart from Neisseria meningitidis, other bacteria that can cause such a condition are Haemophilus influenza and strep pneumonia. The complications are subdural empyema, cerebral abscess, obstructive hydrocephalus, epilepsy, chronic adhesive arachnoiditis, and Waterhouse-Friderichsen syndrome. For the second case study, we've already discussed what a typical clinical picture would look like if someone has increased intracranial pressure. So for the investigations here, the CSF was clear, the pressure was increased, total protein increased, glucose within range, chlorides within range, and on microscopy, the polymorphs were absent, lymphocytes were increased, and no organism was detected on gram stain or Ziehl-Neelsen stain. So what's the probable diagnosis here? Okay, the probable, it's the easiest way to figure out what the probable diagnosis is to look at the cells. So already on the Zil-Nielsen staining, if an organism detected, that rules out any acid-fast bacilli. If there are no polymorphs present, that rules out bacterial meningitis. So the answer could only be viral meningitis, and this is supported by an increase in lymphocytes. So number 2, what are the pictures that help in diagnosis? You can talk about the cells and the clinical picture. Some of the causes of viral meningitis are HIV, Epstein-Barr virus, mumps, and herpes simplex.
Thanks, Angela, but today I'm confused.
And the last question here, just going through the investigations, the physical exam, the CSF is clear and colorless, but forms cobweb on standing. The CSF pressure is increased, total protein increased, glucose slightly decreased, and chlorides are decreased. On microscopy, there were few polymorphs present, lymphocytes were significantly increased, and Zil-Nielsen staining was positive for acid-fast bacilli. So judging by this investigation, the probable diagnosis is tuberculous meningitis. And our diagnosis is supported by the positive staining of acid-fast bacilli. The complications of tuberculous meningitis are hydrocephalus, nerve root damage, and tuberculous encephalitis.
Hi, Angela. Sorry to slow you down. In the chat, someone is asking, can you repeat the one for bacterial meningitis?
Okay. So from the investigations here, white blood cells are increased. Hope you can see. White blood cell is increased. The platelets are within range. And the physical appearance of CSF is turbid. Turbid CSF means that there are white blood cells or pus present. The pressure is increased and is supported by the clinical picture of nausea, vomiting, and photophobia. Proteins are increased, glucose decreased, and chlorides decreased. Now, for the most important part that helps in diagnosis, the microscopy, leukocytes are increased when they are usually absent, and you can see they are significantly increased as compared to lymphocytes, which are just slightly increased. And on gram stain, there were intracellular diplococci demonstrated. So for this, the probable diagnosis would be bacterial meningitis. And we've narrowed it down to Neisseria meningitis because of the diplococci. Haemophilus influenza and strep pneumonia look different. So I said in bacterial meningitis, it's the leukocytes and specifically neutrophils that are increased, while in viral meningitis, the lymphocytes are increased. Also, on microscopy, if you were to have an increase in red blood cells, it would signify that there's some subarachnoid hemorrhage, that there's malignancy, or that there was trauma induced during the tapping of the CSF. Yeah. So I think I've finished. You can go through this at your own time. There's no question regarding it that I have. Yeah. Thank you.
chloride levels are changing. Basically, in meningitis, the inflammation occurs. And when inflammation occurs, permeability of the blood-brain barrier is affected, and now chloride can now start entering. It becomes more permeable, and now chloride can start entering into the, basically leaking into the CSF. So that's why you'll have an increased level of the chlorides. Question. Can you please repeat the difference in the increased leukocytes in viral and bacterial meningitis? So I've sent a great summary on the group. I'm sure you'll see it. We expect the neutrophils to be elevated. Okay. And then in viral meningitis, we expect the lymphocytes to be elevated. Any other question? So the PDF, yes, the PDF will be sent immediately we are done with the discussion. So